2 days of action. Some wanted the levy removed, others wanted it adjusted. Some of ICTU's leadership wanted most of all to be allowed back into their hallowed playground in government buildings. The bleating of some of those princes of public service trade unionism, Bertie's bedfellows, owed more to their sense of loss of status than any real concern to represent the interests of workers. They reminded me of the scene from Oliver, "Please, sir, may I have more?" Or perhaps it should read, "Please, sir, may we be allowed back into your house so that we can play the big boys' games again." The pension levy is a tax on gross pay. It has nothing to do with pensions except that the government, at the behest of IBEC, identified pensions as the hook on which to hang the tax. People in the private sector on defined contribution pensions have seen their pension funds plummet. IBEC, an organisation largely funded by the banks and anxious to divert attention from the failings of their miscreant masters, focused on the bloated, overpaid public service with Rolls-Royce pension schemes as a cause of the country's downfall. Government didn't need much encouragement. The facts were ignored. Public servants like nurses have always contributed to our pension scheme, 6.5%. Pensions are paid from current expenditure. The cost of public service pensions in 2008, above that paid in contributions, was 0.4%, not 7.5% or 10%, 0.4%. And benchmarking to discounted value of public service pensions. Every pay adjudication on the salaries of nurses over the last 25 years has factored in the perceived value of pension. And the result of the imposition of the levy has been an average reduction of 7.5% in nurses' pay. When this is added to the deferral of the 6% under the transitional agreement, nurses are down 13.5%, and that's only the start of it. This must be setting as a background of cutbacks in staffing and resources, which sees nurses pushed to the pins of their collars to try to maintain services to patients. Nurses don't like having to pay more tax. However, we accept the tax increases as equitable and applying to all. We resent the pensions levy as grossly unfair and unjustified. We demand its removal, but it will not be removed unless there is concerted and determined action by the trade union movement. We welcome the anger of the teachers, but one-day protests are useless. We call on all trade unions to enter a campaign of total withdrawal until the levy is removed. Colleagues, the current environment seems set to pose significant internal challenges for the PNA. We have been delighted to note that in 2008, despite the wholesale abolition of posts resulting from Circular 1 2008, that the membership of the PNA continued to grow. In recent months, more nursing posts have been abolished. Now we are seeing the exodus of many more through retirements, and that flood may become a torrent in the coming months. First, as nurses seek access to the public service retirement scheme announced by the government in the emergency budget, and then as they seek relief from the daily torment that is their working lives, as they seek the comfort of home rather than the challenges of a workplace where morale is at lowest possible ebb, and where they fear their retirement gratuity is to be taxed from 2010. As a specialist union representing nurses in psychiatry, intellectual disability, dementia, AIDS and drugs, and other niche practice areas, we have a limited human resource in terms of membership, in terms of volunteer activists and officials. Should the numbers see a real fall, then significant adjustment may be required in the medium term. However, our primary concern has to be the preparation of our branches for the potential retirement of many legendary figures who have led the development of the PNA in various parts of the country, who have been ever present as local and regional leaders, who carry the respect and admiration of the members and management alike, and who may retire in the short term but will most certainly retire in the medium term. A number of training courses are planned for next month, and additionally we have offered to provide local, focused, tailor-made courses in each branch who request it. Please ensure that your branch maximises its participation in these courses. It is also important to state and emphasise that in those areas where new branch officers are elected, our head office staff will maximise their support of those new officers. Colleagues, recruitment has been central to the success of the PNA over the last 20 years. Last year we recorded the highest number of members paying full subs in the history of the association. As we move to this new era in the health service, where retirements peak, where nursing numbers are cut, where the Harney policy of nurse replacement by anything other than a nurse is maximised, the challenges to recruit all and every potential member must be uppermost in our minds. We must also counteract the daft notion promulgated by the Minister and our officials, but unfortunately supported by some lazy researchers and poorly claimed material by the OECD and others, that Ireland has excess numbers of nurses. The recently published tome, The Economics of Mental Health Care in Ireland, contains on page 9 the amazing statement that Ireland has 4 times more psychiatric nurses than any other country in the Western world per head of population. Now, this isn't referenced, it is also incorrect, and I wrote to the authors about this on December 12th last. I'm still waiting a reply. This is the kind of nonsense which creates the impression of waste, overmanning, and the need for pruning of numbers. It feeds the Minister's agenda to reduce costs irrespective of the quality of those replacements. Over the coming months, we will publish more appropriate and detailed comparisons of nursing numbers. However, at this stage, the following is relevant. Most countries do not train undergraduate nurses in psychiatry or ID. As a result, their core nursing numbers are registered nurses, RNs. Only those who go on to study psychiatry as a postgrad are then counted as psychiatric nurses. If the comparison is then made between Ireland and some of those countries, the Irish figures seem excessive, but it ignores the numbers of registered nurses in the comparator countries' mental health workforce. If the OECD or the World Health Organization are provided, and they have been, with the numbers of registered nurses registered with an Bord Electrónis as the reference number, rather than the number in practice, then of course the Irish figure is inflated. And of course, if the Irish figures are misleading, how accurate are the rest? And if reputable academics of the calibre of Dr. Eamon O'Shea and Dr. Brendan Kennedy of UCG can get it so badly wrong, then any policy that is based on this type of material makes no sense. In my work with Horatio, the European Nurse Organisation for Psychiatric Nurses, I will seek to have the real figures confirmed as soon as possible. Colleagues, government and employers have completely undermined the integrity of much of intellectual disability nursing, with the emphasis on the social care model and the replacement of nurses by less qualified staff. I think this will eventually blow up in their faces. However, the lessons must be learned. We cannot permit them to do the same damage to the mental health services. There are currently more than 640 organisations, big and small, providing services to the intellectually disabled of this country. Such multiplicity and duplication is unacceptable and wasteful. I want to welcome the Minister, and this is Minister Maloney's commitment, to reviewing the organisation of those services. Money should not be wasted in duplicating managerial, HR and payroll costs. The term disability covers a wide and diverse range of persons and conditions. When HICWA published its draft standards for residential services for people with disabilities, we were concerned at the absence of a dedicated standard appropriate to people with intellectual disability. And these standards should cover areas including accommodation standards, safeguards in relation to seclusion, least restrictive care consistent with the person's level of disability. And these standards should be consistent with the national quality standards for residential care settings for older people, and should reflect the principles in trying a vision for change in relation to patients with dual diagnosis. We are very concerned that HICWA's draft standards for generic disabilities seems to empower seclusion and restraint without any of the safeguards and the rules published for mental health by